This is the moment where a lot of teams exhale. When everyone starts walking away, like, y'all get here? Nah, bro. This guy has epi still circulating through his system. I give him 3 minutes until his blood pressure drops. Additionally, we still don't know why he coded. And considering all that his body just went through physiologically, like, this is where the storm begins. We call this post-cardiac arrest syndrome.
Hey there, I'm your host, Sarah Lorenzini, a rapid response nurse and educator who loves telling stories to teach critical thinking. This podcast is for nurses who want the knowledge, skills, and confidence to respond to any emergency. With almost 20 years of experience in the ER and critical care nursing, and a master's degree in nursing education, I have a lot of stories to share, and I love to nerd out and break down the pathophysiology, pharmacology, and nurses' role in emergencies. Stories bring learning to life. It is way easier to learn from and remember the stories that my colleagues and mentors have told me than anything I've read in a textbook. And that is why I made this podcast. Every episode is packed full of exactly what you need to know to handle whatever crisis that could arise on your shift. It's one thing to get the right answer on the test, but knowing how to detect when your patient is declining and what to do when your patient is crashing is what will make or break your day and might just save your patient's life.
Hey everyone, welcome back to the podcast. It's been a while since I did a solo show. I've had the privilege of interviewing some awesome guests, which I love, but I also enjoyed the process of preparing for a solo show and drafting out all that I want to share with you. And this topic has been on my mind a lot, especially since I returned from the Revive conference. There's a whole talk about neuroprognostication post-cardiac arrest, and it sparked some curiosity in me and made me question some of my previous perspectives. I actually love when this happens, when what I thought I knew is brought into question, when I'm challenged to check the literature and discover that what we all thought to be true was actually wrong. I can't tell you how many times this has happened in my career, and I know I will continue to be faced with the option of holding on to old dogma or embracing new science and choosing to figure out how to apply new evidence to my practice as a nurse, and in this case, as a resuscitationist. So today we're talking about one of the most critical and honestly, one of the most misunderstood phases of resuscitation care. Because getting ROSC is not the win we sometimes think it is. For Christmas last year, I made everyone on my rapid response team these cheesy t-shirts that said, "All I want for Christmas is ROSC." But really what I wanted the t-shirts to say was, "All I want for Christmas is ROSC with a neurologically intact survival." But adding the last part just doesn't have the same ring to it, and it would have made for a really wordy, busy slogan for a t-shirt. But while I do love when we get ROSC, it's just the beginning. For those of you that are new to this whole resuscitation thing, ROSC is an acronym that stands for Return of Spontaneous Circulation, or the patient got a pulse back. It's what we're shooting for, the entire resuscitation. But once we achieve it, that's when the real challenge begins. And what we do in the next few hours has a massive impact on whether this patient walks out of the hospital or doesn't. So today I want to walk through all of this using a case. We're going to talk through the physiology, the decision-making, the advocacy, and I'm going to anchor all of this to the 2025 American Heart Association post-cardiac arrest guidelines, because there have been some important shifts. All right, here's the case. And as always, I've changed some of the details to protect the patient's identity. So I got called to the step-down unit for a patient with shortness of breath. Immediately, I feel it when I step in the room, that sense that something is very wrong and this patient's about to crash fast, and I don't even have vital signs yet. I can just see it on his face. The primary nurse tells me his patient is a 62-year-old male, history of hypertension, diabetes, and known coronary artery disease. He's been fine, but when we got him up to the bathroom, he started feeling short of breath, so we got him back to bed, called a rapid response. I can see from the foot of the bed that he's diaphoretic, tachypnic, and about that time, the blood pressure cuff finished cycling 74/49. He's drenched in sweat and keeps sweating off his leads, so it's hard to see his rhythm. And now he's minimally responsive, and we can't get the pulse ox to pick up. So I quickly direct the team to get the defib pads on his chest. I grab the bad valve mask and start assisting his ventilations. And I still can't get the pulse ox to read. We're dumping in IV fluids for his blood pressure. My partner is mixing norepinephrine. But within minutes, he deteriorates into ventricular tachycardia and then soon after, ventricular fibrillation. Code blue, all hands on deck. CPR starts, defibrillation, epinephrine, amiodarone, pulse check, VFib, defibrillation, resume compressions. But at the third pulse check, ROSC, baby. Yes, we got a pulse, and I'm stoked. And while the resident and the respiratory therapist are establishing an airway, I'm cycling a blood pressure. 110/65, nice, but not for long. I know better. But this is the moment where a lot of teams exhale. When everyone starts walking away like, y'all good here? Nah, bro. This guy has epi still circulating through his system. I gave him 3 minutes until his blood pressure drops. Additionally, we still don't know why he coded. And considering all that his body just went through, physiologically, this is where the storm begins. The AHA describes this post-cardiac arrest syndrome as a combination of brain injury, myocardial dysfunction, systemic ischemia, reperfusion response, and persistent precipitating pathology. This patient didn't just come back. He's now in a state that looks a lot like global shock and inflammatory cascade and possibly evolving brain injury. Now the real work begins. There is so much to do, consider, anticipate, intervene on. This is going to take a multidisciplinary approach to ensure that all of our hard work doesn't just go to waste and that we can quickly optimize every aspect of the patient's physiology to prevent him from going right back into cardiac arrest. So, first things first, airway and breathing and optimizing oxygenation. We intubated. Sweet. And what's the reflex? 100% FiO2, right? This person was just dead. Don't they need all the oxygen they can get? Is there such a thing as too much oxygen? I think I might have said something dumb like this before, but now I know better. The 2025 AHA guidelines are very clear. Avoid both hypoxia and hyperoxia after ROSC. Hyperoxia is not benign. It contributes to oxidative stress and worsens neurologic injury. So, what should we do? How do we know if we're giving too much? Well, the PaO2 on the blood gas tells us how much oxygen is dissolved in the blood, while the saturation, or SpO2 from the pulse oximeter, tells us how much hemoglobin is carrying oxygen. But the SpO2 of someone with a PaO2 of 500 is still only going to read 100%. There are very few times we need the SpO2 to be 100, and post-ROSC ain't it. So yeah, we started high at 100% FiO2 on the vent, but we titrated quickly, targeting an SpO2 between 90 and 98%, because if the pulse ox is reading 100%, you really don't know how high that is, and we could be overdoing it and causing some harm to the brain. So, at least in my hospital, I would never touch the vent without checking with my RT colleagues. So I chatted with RT, he dropped the FiO2 to 80%, and my patient's SpO2 settled into a nice 96 to 98%. So we just left it there. We have similar goals with CO2 as well. Not too high, not too low. We want normocapnia, 35 to 45, because CO2 directly impacts cerebral blood flow. Too low, cerebral vasoconstriction. Too high, increased ICP. I know we're talking first about airway and breathing, but how precise we are with this part affects the brain too. So this is now brain management also. And please don't take me out of context. There are some exceptions to the rule, but these are some of the pretty general guidelines for managing the airway and breathing in your post-arrest patient. So airway, check. Breathing, ventilation, optimized to shoot for oxygen saturation of 90 to 98%, check. And now, circulation. Remember what I said about the blood pressure? Well, as predicted, the next blood pressure that cycled was 81/40, which gives you a map of 54. We had norepinephrine ready, so we started that and titrated to a map of greater than 65 initially. This can change once we figure out the cause of his arrest. But I do want to pause here because this is often oversimplified. Yes, the guidelines do recommend targeting a map of at least 65 millimeters of mercury. But it also emphasizes individualizing perfusion targets based on suspected cerebral autoregulation and cardiac function. This isn't just about a number, it's about perfusion, coronary perfusion, cerebral perfusion, end organ perfusion. You can jack up the norepinephrine to get a really good-looking number, but you may be treating the wrong thing and not actually helping, maybe even worsening perfusion. Remember, a good blood pressure does not mean adequate perfusion. There's so much more to take into account. And while a MAP of 65 is a starting point, many patients, especially those with chronic hypertension or brain injury, may actually require a higher MAP, as far as like a target goes, to ensure adequate cerebral perfusion. So we might need to start vasopressors. And for other patients, they might do better with a little vasodilation and decreasing afterload to help offload the ventricle. So we need to tailor our approach to our patient's diagnostic results and physical exam. And this patient likely has post-arrest myocardial stunning. So the cardiac output probably is impaired. Norepinephrine is appropriate and is a great first-line agent for most shock states. But we should also be asking, does this patient need an inotrope like dobutamine? Are we treating vasoplegia, pump failure, both? Are they intravascularly depleted or overloaded? What imaging or advanced hemodynamics monitoring can we be doing to figure out what happened and what's the best treatment course to take from here? Because if we just keep cranking up the norepinephrine without understanding the physiology, we may worsen afterload and reduce cardiac output. So as a nurse, I hate titrating vasopressors blindly. I want an arterial line so I can have an accurate map. That's a whole other tangent I could go on, but suffice it to say, the non-invasive BP cuff is giving you a calculated estimate of the map, and that calculation becomes less reliable in shock states or with vasopressor use. Additionally, with an arterial line, some devices allow you to gather some more valuable data like stroke volume variation, systemic vascular resistance, cardiac index, and many more to help guide and tailor the care to the ever-changing hemodynamics of the patient. Next, let's clear up temperature management. We need to talk about this because there's still a lot of confusion. For years, we aggressively cooled patients to 32 to 34 degrees Celsius because we knew it did improve neurologic outcomes, save the brain, right? Then trials came out suggesting that maybe strict hypothermia wasn't actually superior to just preventing fever. And since the TTM2 data came out, I've heard people say things like, oh, we don't do targeted temperature management anymore. But that's not what we should be taking away from those trials. So what do the 2025 AHA guidelines say? Well, they recommend actively preventing fever and maintaining a controlled temperature between 32 degrees Celsius and 37.5 degrees Celsius for at least 24 hours. So they kind of left it up to the clinician depending on what factors contributed to their arrest and the specific circumstances of their arrest. It is a risk versus benefits consideration. Like, how much of a hit did the brain take? There are definitely risks to hypothermia, from electrolyte shifts to arrhythmias. Plus, it's very labor-intensive for the nurse to keep the patient hypothermic. But to be very clear, they never said, don't worry about the temp anymore, y'all. They just allowed for cases when extreme hypothermia wasn't necessarily needed. So this is the key shift. It's not cool everyone aggressively or else. Now it's control temperature and prevent hyperthermia. And here's the physiology. After cardiac arrest, the brain is incredibly vulnerable. Even mild fever increases metabolic demand and worsens neurologic injury. So whether your institution targets 33 degrees or 36 degrees, the takeaway here is this. Temperature is important. So pick one that's the best for your patient considering their specific situation. At a minimum, avoid fever for all patients. And avoid rapid fluctuations in temperature, like from shivering. How we rewarm is just as important as the target temperature, because rapid rewarming can worsen neurologic injury as well. So this needs to be controlled and gradual. I think we're still waiting on more studies to guide us if there are specific temperature targets for specific circumstances. But until that comes out, the AHH is kind of leaving it up to the discretion of the clinician, recommending a wide range of 32 to 37.5. And I'm cool with that. All pun intended. Okay, next, prepare yourself for my soapbox about sedation and analgesia post-intubation because I'm really passionate about this one. So in this particular case, the patient was intubated right after ROSC, and the resident was able to visualize the cords and get the ET tube in without sedation or paralytics. Strong work. We often refer to those two medications, the sedation plus paralytic combo, as RSI, or rapid sequence intubation. We need to rapidly take control of the airway. We can choose a combination of a fast-acting sedative like etomidate or ketamine and a paralytic like succinylcholine, rocuronium, vacuronium. I have 2 entire podcast episodes where I talk about administration of these drugs and how to manage them. It's episode 73 called Resuscitate Before You Intubate, and I did a bonus episode pod swap with the Straight A Nursing podcast back in March of 2024, all about just RSI drugs specifically. So check them out if you want a deeper dive on this one. But in summary, we give these 2 drugs, we drop the tube, and then depending on which paralytic you choose, often the paralytic has a much longer half-life than the sedative, and the patient could become fully awake, but they look like they're sleeping comfortably because they're still paralyzed. This is literally my worst nightmare, to be awake with a tube in your throat, and you cannot breathe, you cannot blink, you cannot move, you cannot communicate. Yeah, no thank you. Not for me, not for my worst enemy, and definitely not on my watch over my patients. And while you would think that would be obvious, that we shouldn't be allowing patients to be paralyzed but not sedated, I still see this handled poorly. They're intubated, but lightly sedated. Like the sedation was started at the lowest possible starting dose and definitely not high enough to ensure sedation, or the patient's not adequately treated for pain and they have a diagnosis that's painful. And this is what makes my blood boil, is when I inquire about the sedation and the response I get is, well, they were hypotensive, so we didn't want to drop their blood pressure by titrating out the sedation. Are you kidding me? You know we have things for blood pressure, right? Like norepinephrine is a much quicker fix for their blood pressure than the years of therapy they're going to require from the trauma you're inducing by allowing a patient to be paralyzed and awake. That is absolutely unacceptable excuse for not adequately sedating your paralyzed patient. Since when is pain or emotional distress a vasopressor? You don't treat hypotension with terror. You treat hypotension with vasoconstrictors or volume replacement. Now, yes, some sedatives can drop blood pressure, so we should be thoughtful about selecting the agent and the dosing, but that's not an excuse to leave a patient inadequately sedated. So aside from it just being the right thing to do, why do we provide adequate sedation and analgesia for a comatose post-cardiac arrest patient? Well, because treating pain and anxiety reduces metabolic demand. That's helpful. Treating pain and providing sedation improves ventilator synchrony. And ultimately, this actually helps to protect the brain. So yes, it's about comfort and compassion for what they're going through, but it's also about neuroprotection. Quick disclaimer, because I know there's some of y'all that are saying this. I'm not talking about long-term, just for the first couple of hours post-arrest. We know patients do better and recover faster when they are awake and participating in their care, even while intubated. But I'm talking about when they can't participate because we paralyze them with a medication that's going to linger in their system for 45 minutes. Those patients I will gladly sedate and start vasopressors if I need to ensure they maintain a safe blood pressure. Okay, let me step down from my soapbox now and talk about diagnostics. Hey guys, I just wanted to take a quick break to talk about something that I think is really important, and that is getting certified in your nursing specialty. Not because having the extra letters behind your name make you a better nurse, but because taking the time to deep dive into all that you need to know for your specialty, putting in the study hours, and dedicating yourself to mastering what your patients need you to know how to manage them best, the prep for the exam, is what will make you a better nurse. So whatever specialty you are currently working in, go study for that certification exam. And if you're a critical care nurse, I have something that will help you pass your CCRN. My friend Nick McGowan has an excellent online self-paced CCRN prep course called Critical Care Academy. It is so thorough, and he has broken down everything you need to know into little bite-sized digestible content that he calls micro-learning. Let me tell you, the CCRN is the hardest test I've taken in my entire life. You don't want to go it alone. You want to take this course to ensure that you know your stuff before sitting for the exam. If you'd like to check out his course, you can find it at ccrnacademy.com. And great news, just for being a Rapid Response RN podcast listener, you get 10% off the cost of the course by using the coupon code RAPID10 at checkout. So if you've ever considered getting your CCRN, do it. And let Critical Care Academy help make sure that you will pass. I'll put the link and coupon code in the show notes. I'm talking about this after talking about airway, breathing, circulation, optimizing hemodynamics, ensuring adequate sedation. Treat the patient first. We can get them to CT in a bit once we know all the life-saving and basic human decency stuff is taken care of. But first, that's the priority. Then, diagnostics are important. We cannot treat this patient effectively if we don't identify the cause of their arrest. So in this case, I had a high suspicion for acute coronary syndrome. Diaphoretic upon arrival, impending sense of doom in his eyes, VT to VFib, arrest, responded to the second shock. That's got STEMI written all over it. But there's several things that could also fit this presentation, and we don't know which one we're dealing with or how to treat it until we do diagnostics. So, what should happen quickly? 12-lead EKG, troponins. Consider maybe a cath lab trip, maybe a CAT scan. My providers at my hospital actually often do a quick point-of-care ultrasound to rule out some of the more common causes of arrest, looking at the heart, the lungs, the abdomen. And the AHA continues to support early coronary angiography for patients with suspected cardiac arrest, especially those with elevated ST segments. Just a quick side quest on the timing of the EKG post-arrest. There is some debate about when to obtain the EKG. Often the heart is a little stunned after all it just went through. Being pounded on with compressions and then jolts of energy going through it with defibrillation. And sometimes that initial 12-lead EKG can show some ST segment elevation when there isn't actually any coronary occlusion, just some myocardial damage from multiple factors that don't require a cath lab. Just a little time and some good nursing care. So the timing of the EKG can be tricky. Immediately post-ROSC, you can see some transient changes from global ischemia or defibrillation. So not every ST elevation equals coronary occlusion. But we should still obtain an EKG early on and interpret it in the clinical context, because if this is a true STEMI, we don't want to delay reperfusion, but at the same time, we want to try to avoid the unnecessary cath lab activation and sending a patient for an intervention that won't actually improve their outcome. So, how long do we wait to activate the team? I will leave that one up to your local team. Just know that there is some nuance here regarding the initial EKG post-ROSC. But even without a STEMI, we should be thinking critically and ruling out all the possible causes for the arrest. Did they have a PE? Do they have electrolyte abnormalities? Are they septic? Are there intracranial events? Post-cardiac arrest care needs to start with optimizing the patient's oxygenation, ventilation, and perfusion. But we do need to get to the bottom of what led them here in the first place, because many of the potential causes of cardiac arrest, if not addressed, will cause the patient to re-arrest. So just be prepared for a road trip or two to pursue your diagnosis. So what did my patient have? Surprisingly, not a STEMI. We were all wrong. Though, my experience with STEMIs that code is that they have this ventricular arrhythmia. We get ROSC early on, and often they actually wake up and are pretty neurologically sound because we were down just for a short time. But my guy didn't wake up, and he had no RSI meds on board. He was unresponsive, which leads to our final section today. Let's talk about neuroprognostication. Time to debunk some things. So this is where I want to challenge some old thinking. There was a time when fixed pupils, no motor response, early EEG changes were all considered poor prognostic indicators that led us to believe that this patient was unlikely to ever have a meaningful neurological recovery. But the current guidelines strongly caution against early prognostication. In layman's terms, we used to make predictions about a patient's likelihood of survival based on things like pupil response, motor response, how much brain activity on EEG, even early on after their arrest. But now we know all of that can look pretty ominous for the first 48 to 72 hours and then start to recover. Why? Well, because sedation compounds the exam, hypothermia alters neurologic response, and brain recovery just simply takes time. So the AHA recommends delaying neuroprognostication for at least 72 hours after return to normothermia. So when someone says, they're not waking up, this looks bad, we need to pause that narrative. I need to be okay with saying, we don't know yet. I need to allow myself to consider the option that there is hope. Even if I'm looking at fixed pupils in a patient who's not waking up, it is too early for any of us to know. Additionally, there are so many ways to truly evaluate a patient's neurological status and make a prognosis about their chance of survival, from lab values to imaging to additional physical findings, but all of those are irrelevant in the immediate post-ROSC period. So, I would encourage you to check out the guidelines and involve yourself next time the neurologist is consulted for neuroprognostication. Watch their exam, ask questions, look up the labs they order, inquire how they make their determination. This is a fascinating and growing field of study that will greatly impact how we talk to families and how we care for patients now and in the future. Speaking of talking to families, this one's the hardest part. The family always asks, is it going to be okay? And the honest answer is, we don't know yet. But how we say it matters. Saying dismissively, I don't know, or no way to know, it's not going to land very well. This is where your calm presence matters, and taking time to explain with clarity and compassion is just essential. Something like, right now our focus is stabilizing his body and protecting his brain. It's too early to know what his neurologic recovery will look like. Over the next few days, we'll know more as we see how he responds to our interventions. But to be very honest, we need to wait until then to give you any predictions about his chance of recovery. But know that we're doing everything we can to give him the best chance. No false hope, but also no premature conclusions. This is a difficult balance. I get that. Ooh, okay, this is getting long. But if I had to boil all this down, I would say your priorities in those first hours are optimize hemodynamics, prevent hypoxia and hyperoxia, control temperature, ensure adequate sedation and analgesia, initiate the diagnostic workup, and advocate for whatever escalation your patient needs, be it an echo, the cath lab, maybe an interfacility transfer, and most importantly, stay vigilant, because these patients can rearrest. They can spiral quickly, and you will likely be the first to catch it. So don't put down your guard or just go celebrate the ROSC you got. Stay locked in and attentive, anticipate changes, and respond quickly. So let's go back to my patient and talk about how to advocate for these priorities that I just listed. Say you work at a facility where the providers don't routinely do bedside point-of-care ultrasound, so you have to wait for a full echo to be completed. Your patient's on norepinephrine and you're able to get the MAP greater than 65, but you keep having to go up on the dose. And his lactate is rising and his skin remains cool with poor capillary refill in his extremities. Bedside echo shows up, looks like poor LV function. This is your moment as the nurse. You don't need to wait for the cardiologist to read the echo and dictate her report for the intensivist to finish rounds to see the report. You just ask the tech, does heart function look okay? What do you think? And then you advocate. Hey, doc, I keep having to go up on the norepinephrine and the patient's perfusion hasn't gotten any better. They're still cold and poor cap refill. Or like, hey, thoughts on adding another agent? Would you like to add dobutamine? Or should we consult cardiology or maybe mechanical support? Do you want to repeat the EKG? Like, this is where the nurse changes the outcome. Y'all, we can do so much more than follow orders and provide care. That's important. But if we can understand the physiology, we can be pushing the conversation forward, anticipating what's next, and preventing decline. So here's my final thoughts. ROSC is not the end of the goat. It's actually the beginning of a very fragile window. Survival with good neurologic outcome depends heavily on high-quality post-cardiac arrest care. So next time you hear, we got ROSC, I want your brain to go, okay, now the real work begins. Let's do this. If this episode resonated with you, or if you've had a post-ROSC case that stuck with you, I'd love to hear about it. Send me a message on Instagram. I'm the Rapid Response RN. IG is really the only platform that I'm active on these days. And if you found this episode helpful, please share it with another nurse who cares for these patients too. This is not the stuff we gatekeep, because this is the kind of knowledge that changes outcomes. So thank you for sticking with me till the end. This is a longer episode, but I hope it gives you the knowledge and the confidence to advocate and provide the very best care to your next post-arrest patient.
Before you go, I have an exciting announcement. You can now earn CEs for listening to this podcast. That's right. Our Renegade has teamed up with podcast hosts like me who are delivering amazing content that not only educates, but inspires you to be the best for your patients. You get to learn and earn continuing education credits while absorbing knowledge from thought leaders and innovators in the field of health and medicine. You're already listening to podcasts during your commute, at the gym, or while unwinding after a long day. So why not earn your CEs at the same time? And that's where pod classes come in. Yep, it's just what it sounds like. It's CE learning through podcast. To learn more, I put a link in the show notes for you. Well, thanks for listening. I hope you learned something that will save a life. Remember, nursing is a team sport, so trust your intuition and don't give up advocating until you are confident you've done what's right by your patient. The views and opinions expressed on this show are that of Sarah Lorenzini's. That's me and mine alone. They are not intended as medical advice and should not take the place of your institution's policies or procedures. Evidence-based practice is ever-changing, and your patient care should reflect the current best practice. So if you want to get in contact with me, you can shoot me an email at sarah@rapidresponsern.com or on all social media platforms as the Rapid Response RN.